but important, and that is, I'd like to convince you that there's a faithful, ethical, effective method that's available to women and their families when their fertility is in question. Said differently, a woman and her spouse should never have to choose between their faith and their fertility. And I'm sure everyone in the room, either personally or anecdotally, knows times where that happens. I see it every day in my practice. And usually that talk ends up with tears on the woman's face because maybe they spent the last 3 to 5 years abandoning the teachings of their faith because they thought they had no choice. Well, I'm here to tell you they do have a choice, and there's a better way. And so I hope I convince you of that by the time we finish our time together. So I'm going to give you, in order to do that, I need to give you some background. I apologize. I hope this projects okay. I want to give you some background about the Creighton Method in general, because in order for us to have a good discussion about the practical applications of Creighton model NAPR technology when there's a fertility problem, we need to build a little bit of a vocabulary and an understanding of normal. So I want to do that. Said differently, I'm going to make you an expert on the menstrual cycle. I bet you didn't think that's what you signed up for today, but that's what you're going to get. We'll talk some practical applications, and then if you're not sick of listening to me and there's time, I'll tell you a little bit about my sort of crooked, serpiginous journey to becoming an NFP only provider. So let's start with the overview. Women's menstrual cycles and their fertility cycles, I think most people would say, has been shrouded in mystery since the beginning of time, right? I mean, is there any topic that intimidates us men particularly more than a woman's menstrual cycle? You know, when I see couples that are not using a charting method, and I'll ask the husband, what's your wife's periods like? And I usually get sort of, he'll say, I'm pretty sure she has them. Occasionally I'll see feminine products in the trash can. I have no idea. When you ask a Creighton NAPR technology couple, when I ask the husband what his wife's periods are like, she bleeds 5 to 7 days, some moderate, some light. She tends to peak around day 60. I get a lot of data because it's pro-couple and pro-information. But in general, most women know very little about their fertility and their fertility cycles. I think that's a blanket statement that's pretty supported. I believe, as most of us I think would, every woman deserves to understand her body and her fertility. And it's our job to make that known. If for no other reason, in the process of understanding the fertility and the woman's cycle and the beauty and the majesty of that, you begin to appreciate just how holy reproduction is. So we're going to talk about the method. It's an observational method, Creighton is. It's a prospective method. I want to know what's going to happen, not what has happened. I talk about that sort of like driving down the interstate looking in the rearview mirror. It can be done, but you're finding out what just happened. I want to know, particularly in a disease state, what's about to happen, or what should be about to happen and isn't. So this is a prospective method. It uses a standardized vocabulary that's been worked out over the last 3 decades. That's the same in Europe as it is here, as it is in South America. And it's based on a pretty simple concept, that the fertility window exists, that it can be recognized, and that couples can use the data they gain as they wish, right? By that I mean they can use that information to achieve pregnancy or to avoid pregnancy as they wish. So it's actual fertility management. It's not birth control, it's fertility management. And as a nice bonus, this doesn't project well, it just so happens that it's completely consistent with the teachings of the Holy Church. That's an important little asterisk to add on, right? So as we move on a bit, as I said, the method is natural, it's effective, it's actual fertility management, as I said. It is not contraceptive, it's moral, it's effective, and it's actually pro-relationship. Now, I'm speaking to a select group. This is where I would usually digress a bit, but I don't think anybody would suggest artificial contraception is pro-couple. That's a hard argument to make, right? If I'm talking to someone that doesn't agree with that argument, we usually digress and start talking about sterile sex. And I ask them about that, and I find a way to say, that's sort of like, and I hope I don't offend anyone, that's sort of like homosexual sex, isn't it? So that's sort of like what you're doing when you contracept. Not always popular when I bring that up, but it usually helps people understand we're talking about something that's pro-couple, it's not contraceptive. So there's an unexpected bonus of the Creighton model NEPR technology. It just so happens that it's phenomenal at dealing with the abnormal. Women with irregular cycles, with anovulation and polycystic ovarian syndrome, with dysfunctional periods, with severe PMS, with the litany of things, including preterm birth and recurrent pregnancy loss, and managing those otherwise very difficult to manage problems. And so not uncommonly in the doctor's lounge, a physician will get the nerve and they'll say to me, "So I hear you don't prescribe artificial contraception." That's right. "So you just tell young women that are having irregular periods, too bad, go away?" And I said, "Yeah, that's exactly what I tell them. I'm sorry. There's nothing that can be done." Obviously not. It's a phenomenal method that we'll talk about more in detail of treating most, if not all, of the common problems related to the menstrual and fertility cycle. Again, daily observations, just a quick overview of the method. Daily observations of cervical mucus and an external evaluation of that. Labeling of a day as either a fertile day or an infertile day based on those observations and understanding what they are. And a key component, this doesn't project, I'm sorry, cervical mucus changes precede ovulation. It's prospective. And we'll talk more about that in terms of hormones and graphs and things in just a minute. Does anybody want to stop me yet? I can already tell I'm losing my voice. This is not good. So I want to show a menstrual cycle. So this is what a Creighton chart looks like. With stickers that are either red, white, or green. Red is obviously a menstruation. Green is a dry day where there's no mucus observed at all. And the white stickers are when there's mucus. And I know that it doesn't project, but beneath each of the little white baby stickers, there's a series of numbers and letters that's part of the standardized vocabulary that's used to describe how fertile that mucus is. But this is what a normal chart looks like. So clearly menses, this is the infertile days, followed by a fertile period, followed again by an infertile period. That's pretty straightforward. That's a textbook normal cycle. And I say it that way because I'd ask anybody here, what percentage of American reproductive age women have 28-day cycles with an ovulation day on day 14? Anybody want to hazard a guess? High or low? Excellent, that's right. About 10%. If you select out perimenopausal women, if you select out adolescent young women where their periods tend to be naturally irregular, and look at that subset of women who are not taking oral contraceptives, about 10% of women have textbook 28-day cycles, right? Yet every woman thinks she's supposed to or thinks she does. One of the things that amazed me when I'd made the transition from a regular OBGYN to the right kind of OBGYN was all of the women that I'd seen before that told me they had regular cycles. When they started charting, their cycles weren't regular at all. But they said, I have them monthly, about once a calendar month. But when you actually start digging into that data, it's not very regular at all in 90% of healthy women. So there's a huge problem with expectations sometimes. So this is the same chart with what I've done now is just superimposed every other day blood test of estrogen. So let's talk a little bit about what happens hormonally in the menstrual cycle, in a normal cycle. So the black bars are estrogen, the red bars are progesterone. So in the beginning of the cycle, as the period's coming to an end, a follicle begins to grow, the follicle makes estrogen. And as the follicle increases in size, exponentially, so too increases the estrogen level. At a point, the estrogen level peaks about the time the follicle ruptures and the egg pops out. It makes a corpus luteum. I'll show a picture in a minute. And then progesterone goes up. And then progesterone stays elevated by that corpus luteum for roughly 14 days, theoretically 14 and 14, 28. For roughly 14 days, that little corpus luteum makes progesterone. Progesterone is where the money is in the menstrual cycle, right? The corpus luteum, for all intent and purposes, is the only thing in the body that makes progesterone. And it makes progesterone for a fixed period of time, about 14 days. And it's waiting on a message that says, I'm pregnant. So sperm and egg meet in the end of the fallopian tube. Immediately they start making HCG, human chorionic gonadotropin. Other than turning a pregnancy test positive for us, the role of HCG is to tell the corpus luteum in the ovary, we're pregnant, don't stop making progesterone. Because progesterone stabilizes the lining of the uterus called the endometrium. Estrogen makes it grow and get thicker. Progesterone stabilizes it and supports it. So if that signal of HCG doesn't come to the ovary, at the end of about 14 days, the corpus luteum dies, progesterone production goes to nothing, it drops, and it's that sudden drop that signals the lining of the uterus, we're not pregnant, have a period, start again on the next cycle. So if you think about it, from the moment of conception, the fetus is in charge of its own environment. That's kind of cool, I think. It's not a hunk of tissue floating down the tube. It's a baby that's in charge of its own environment. So the HCG stimulates the corpus luteum to make progesterone. We often give women HCG injections to stimulate their own corpus luteum to make more progesterone, just like the baby does. But in the absence of that, the progesterone drops and a period starts. This is just a different way to tell the same story with pictures. So in the beginning of the cycle, this is showing menstrual bleeding. Then the lining of the uterus goes down really low. The follicle starts growing. A follicle is nothing but a cyst with an egg in it, right? Another way to say ovulation is to say ruptured ovarian cyst. It just doesn't sound quite as genteel, but that's what ovulation is. A follicle is a cyst that has an egg inside. And the follicle grows under the influence of follicle-stimulating hormone. And as it grows, the estrogen production goes up. The lining of the uterus gets thicker. The follicle gets bigger. Then all of a sudden, the follicle explodes and the egg pops out. And what used to be the follicle then becomes the corpus luteum. That's Latin for yellow body. It actually looks yellow on an ovary. And that corpus luteum, as I said, makes progesterone for about 14 days. And that stabilizes the lining of the uterus here. It keeps it the same thickness, and it's just sitting there waiting on that signal. So here I've just superimposed the two, but you can see what's happening. As the follicle's growing, the estrogen level is going up. At the time the estrogen level surges, the follicle explodes, the egg pops out, and then here comes progesterone from the yellow body. And that is the normal menstrual cycle. Now the fact that we know that, we can use all of that information when there's a problem. If a woman doesn't appear to be ovulating, if the lining of the uterus doesn't appear to be appropriately thickened or appropriately supported, we can use all of that to diagnose a problem and then to treat it and reverse that. Questions at all? Anybody? Please. What if you don't have a period? Great, we're going to get to that. That's an excellent point. So if you don't have a period, why? What's going on? Your chart doesn't look like this. There's a couple of ways it can look, and I have an example in a second. Anything else about menstrual period hormones? Now see, you're a menstrual hormone experts. If you captured this, you'd know more than 99% of physicians in practice, I would say. So you're doing well. So this is a real chart from a real woman. And this is, again, menses, dry period, fertile period, peak day or ovulation followed by an infertile period. Now at first glance you might think, well, she's got irregular periods, right? They vary from 22, 24 to 33 days. She must be all over the board. There must be something wrong with her, right? All of my colleagues in practice would put her on the pill to regulate her periods because they're bouncing around. Well, it turns out her cycles are perfectly normal because the distance from peak to period, or the post-peak phase, varies by only plus or minus 2 days, and that's normal. What varies in this cycle is the pre-peak phase. This area, that's perfectly fine. There's nothing abnormal about that at all. But her post-peak phase is fixed. We could just move a caliper around on her whole chart and see that that never changes. So she would have reported irregular cycles. We started charting using the Creighton Method technology. Now I know she's got very regular, very normal cycles. So again, to sort of summarize a bit, the method is effective. 99+% effective in avoiding pregnancy. Now you'll be told that oral contraceptives are 99% effective. There's always a big asterisk beside that. You know, it probably says at the bottom of the page, except when they're not, right? In my years in practice, I have delivered a lot of pill babies. Not because they took medicine on the pill, not because they skipped days, because it doesn't work that effectively. Now that's a secret that you're not going to hear on CNN, but it happens. Trust me, it happens. I could introduce you to the young women who've had pill babies. 99% effective in avoiding, 98% effective in achieving within 6 cycles. If a couple is charting and they can recognize the normal biological markers on their chart, like I showed, they're going to conceive within 3 cycles, likely. Within 6 cycles, 98%. If they don't, by definition, there's a problem. It's as effective or more effective in some cases than in vitro fertilization and so-called assisted reproductive technologies. I'm going to show you some data on that in just a minute. And it's a problem-based approach. Now, I would argue that's a key point. I'll editorialize. This is opinion. The trouble with mainstream gynecology is when it looks at infertility, it doesn't look at it as a problem-based approach. Or if it does, those physicians look at the wrong problem and they ask the wrong question, right? They want to treat the symptom. So if a couple goes to a reproductive endocrinologist that does IVF and does intrauterine insemination, they'll say we can't get pregnant. The reproductive endocrinologist will say, and that is the problem, you're not pregnant, I can make you pregnant. And they can make you pregnant. In the Creighton world, we would argue the problem is not that you can't get pregnant. That's a symptom, like pain, like chest pain, like a heart murmur. That's a symptom of the problem. But there's another problem. We need to find out what that problem is. I'm not going to just treat the symptom. I need to find out what your problem is. Now, outside of gynecology, I don't think there's another discipline in medicine that would endorse treating the symptom without understanding what the problem is. I mean, imagine, you go to an orthopedic surgeon, my knee hurts. He says, it's not a problem. Take this pill, it'll make the pain go away. And you say, terrific, thank you. No, you'd say, what's wrong with my knee? Do I need an MRI? Do I need a CT scan? Do I need physical therapy? What's wrong with my knee? Why is it hurting? Outside of gynecology, that's never done. That'd be irresponsible and short-sighted. In gynecology, it's done every day. You can't get pregnant, that's the problem, we'll make you pregnant. To further editorialize a bit, fertility is a state of health, right? By definition, a woman is supposed to be fertile. That's a state of health. If you're infertile, not conceiving, that's a state of unhealth or dis-ease. If a woman can't conceive, something is wrong. Maybe the woman has polycystic ovarian syndrome. Maybe she's got undiagnosed diabetes. Maybe she's got thyroid dysfunction. But there's something wrong if she can't conceive. Sadly, at least we in the sense of our public policy makers, think that fertility is something that needs to be treated as a disease. Contraception is part of reproductive health, right? We have to prevent fertility. Yet very few insurance companies cover treatment for the actual disease, which is infertility. I won't editorialize too much more, but I think you can see that's a problem. That doesn't make sense. It's fundamentally flawed logic. So I said I would show you some effectiveness data. This table looks at sort of a summary of published effectiveness data on various methods. So this is NAPR technology, Creighton fertility model versus assisted reproductive technology, traditional gynecology with in vitro fertilization, right? If we look at the success rates of achieving pregnancy in women with endometriosis, on my side of the equation, we're 56 to 76% successful versus 21% with IVF and assisted reproductive technologies. I'm not making that up. That's from published data. If we look at polycystic ovarian syndrome and achieving pregnancy, 60 to 80% successful we are versus 25 at best on the reproductive side. Continuing premenstrual syndrome, in 95% of cases, we can completely eliminate severe PMS versus 43 published for traditional methods, typically using antidepressants. That's a vast difference. Postpartum depression, 92 to almost 100% successful. Best case scenario, slow improvement over 6 to 12 months using antidepressants. Again, prematurity rate down to 8.3%. I'm going to talk a lot more about that versus 17-18% prematurity rate and the traditional approach to pregnancy problems. And then finally, recurrent pregnancy loss, an area that I spend a lot of time working in. I'm going to move this so it doesn't pick me up. There we go. 79% reduction in recurrent pregnancy loss versus unpublished data that's just poor. So there is a scientific basis for the NAPR technology Creighton approach. It's ethical, it's effective, it works. Any comments, questions? Yes, please. Period. Endometriosis, the number 2 criminal suspect in all things fertility, right? Endometriosis, at least 50% of women who have polycystic ovarian syndrome also have endometriosis. At least 50% of women who have endometriosis, their only symptom is they can't conceive. So I tell a woman, I think we need to consider endometriosis. I don't have any pain. There's a 50% chance you have it and you don't have pain, right? So that makes diagnosis a challenge. It is a bizarre disease. There's no male equivalent. There's no mammalian animal equivalent. It only exists in human females. The lining of the uterus is called the endometrium, and endometriosis is when that endometrium somehow spreads outside of the uterus and attaches in places like a cancer would, and it still behaves like it's inside the uterus, just like a cancer does. So as the estrogen stimulates the lining of the uterus to grow, that endometrium, wherever it is in the body, it grows. When the progesterone says bleed, that endometrium bleeds. Well, it is not normal to have bleeding inside the pelvis. Blood is incredibly inflammatory, and so things stick to things. It's like putting super glue in the pelvis. The intestines stick to it. The fallopian tubes stick to it. It can be on the liver. It can be in the lungs. When we lived in Georgia, we had a patient who had a seizure. Every time she had a period, she had endometriosis in the brain. It's a bizarre disease, very bizarre. It's common. It's commonly overlooked, sadly. It's a parasitic endometrium that gets outside the uterus. We don't know how it gets there. It has devastating effects on fertility. It causes infertility in 2 ways. One simple, one not. The simple way is it blocks the tubes. That's like having your tubes tied. The sperm can't get through to get to the end where the egg is. The more complicated way is through that inflammatory component that I mentioned. When it's in the pelvis is full of fluid, peritoneal fluid, and the endometriosis is very inflammatory. And the prevailing sort of wisdom is it creates this huge inflammatory reaction in that fluid that is toxic to sperm and egg. Because I can see a patient who's had infertility for 10 years. We do laparoscopy. She's got a little pencil head size endometriosis. I cut that out. She gets pregnant the next cycle. Doesn't make sense. It's very inflammatory, and we believe that's how that works. At the same time, I can see a woman that maybe you do a laparoscopy for something else, and she has 7 kids, and she has endometriosis all through her pelvis. Never slowed her down. That doesn't make sense. But it's a goofy, mysterious disease. The treatments for endometriosis, now, as a Creighton provider, NAPR technology, I will tell you it's a surgical disease. There is no data that says birth control pills help endometriosis, yet that's the most common treatment of endometriosis is oral contraception because it makes the patient go away happy. She's having painful periods, painful intercourse. If we put her on the pill, her symptoms get better. We could do the same thing with narcotics. Her symptoms would get better. She wouldn't feel them, right? But birth control pills do nothing to treat endometriosis. In fact, it just marches on. So a sad scenario is a young woman, 13, 15, 16, gets put on the pill because of her wacky, painful periods. She gets better. She stays on the pill 10, 15 years. Now she's married, wants to be pregnant. She stops the pill, fully anticipating to be pregnant the next month. Nothing happens. Nothing happens. Nothing happens. Eventually she comes to me. I look, she's got endometriosis that she'd had since she was 14. It had just been covered up. Our approach to endometriosis is to treat it like a cancer. We cut it out, right? I wouldn't say to you, you know, you had ovarian cancer and I went in and I got a lot of it, but I left some of it back because some of it was in an uncomfortable spot for me to get to, but I think you'll be fine. I would never do that. We treat endometriosis just as seriously. I treat it like it was a cancer. No matter where it is, we cut it out. And that's the best way to improve fertility, and it's the best way to postpone its recurrence. Endometriosis always comes back. I wish we could see this. This is a picture of endometriosis at laparoscopy. If you're interested, you can come look at my laptop later. It used to be called a gunpowder lesion, like someone threw a fistful of gunpowder and it sort of splattered against the wall. But if we take a biopsy of this and send it to the pathologist, it looks just like the lining of the uterus. It is the lining of the uterus stuck in her pelvis. Very bizarre. That's another picture of it. You might be able to see that one a little better. What you can't see here is all of these lines. This is scarring. And then this is an adhesion from the intestine that's right here that's stuck. That's a good example of how things just stick to it. So when I'm treating this, I'm going to cut all around here. I'm going to take all of this out with a wide margin. And then I'm going to laparoscopically sew this back together so there's no raw edges to cause scarring for the bowel to stick again or the fallopian tube to stick again. And it causes a lot of pain when it causes symptoms. Again, 50% of the time it doesn't. I had an endometriosis movie, but I'm going to skip that as well. So this is a couple of practical chart-based problems. This woman has what's called an inadequate mucus cycle. She has no mucus, right? Remember, the estrogen goes up and the white babies appear on the white stickers because the cervix makes mucus in response to estrogen. She has an inadequate mucus cycle. Just by looking at her chart, I know that she either has something wrong with her cervix or she's not making enough estrogen. I can give her a mucus enhancer like Mucinex, vitamin B6, amoxicillin, and or I can test her estrogen through here and supplement her to give her better mucus. You have to have mucus for sperm transport to get them inside the uterus. So if she's infertile, she doesn't need IVF, she might need vitamin B6. This woman is anovulatory. So this is to the young woman's question, what if I don't have a period? She's never going to have a period. She doesn't ovulate, she's just a sea of green stickers. And that might go on 5, 6, 7 months. This is what's called a luteal phase defect. She makes a corpus luteum, right, the little yellow thing. It makes progesterone, but it only makes it 5 days. That should be 11 to 17 days. So she has what's called luteal phase defect. If she conceives, virtually guaranteed she's going to have an early miscarriage. Easy to fix. We just give her progesterone in the post-peak phase. Now we have to know when peak is, so I've got to have her chart because I need to be able to hone in like a laser on peak day +3. We start her on progesterone and she takes it for 10 days. So if she conceives, there's enough progesterone to support the lining. A lot of the time when we see women with recurrent pregnancy loss, it's luteal phase defect. And this is probably a phenomenon called a luteinized unruptured follicle, LUF. When I was in residency training, I was taught that LUF was a thing of the past. It didn't exist. We see it every day in my practice. I should call my instructors. That's where she makes a follicle. It gets large. It starts to make progesterone, so it postpones the cycle, but she doesn't ovulate. The follicle never ruptures. It just sits there. I'll show you a picture of that in a minute. This is just a fun example. This is from Dr. Hilder's data at Creighton University. This is a woman who had IVF, IUI, years and years of infertility. She has no mucus cycle. They started her on vitamin B6. One little mucus day popped up and they used it accordingly. That's what the eyes are, intimacy. And she gets this, pregnancy. Can you imagine failing IVF at $30,000 a try and failing IUIs at $5,000 to $10,000 a try, and you take about $10 worth of vitamin B6 and you get pregnant? You'd be happy and angry at the same time. This is an example of male factor infertility. Now that's a whole seminar in itself, but very commonly we find men not with aspermia, they're missing sperm. That's actually incredibly rare, but a sperm issue. Typically a man should have about 20 million sperm. This has 700,000, yet they achieve pregnancy. So at around 1 million mark, which the urologist will tell a man, you're infertile, you're sterile, no way you can conceive. Because all of the numbers on the normal semen analysis report are geared towards shifting people to IVF. We see routinely pregnancies in the 1 million area because they can laser in on ovulation. They can pick ovulation using the Creighton charting method. Excuse me. And they can laser in on that, so when there's reduced sperm motility or a reduced count, they can still conceive. So male factor infertility is a whole topic in itself. Got a lot of psychology that goes along with it, but there's a lot of hope using the Creighton Method technology approach. Questions? I was hoping there'd be a question while I could stink a drink. Oh. No. Are these considered normal acceptable ranges? No, this is abnormal. Yeah, it's only 700,000. It really should be 20 million. But my point is, even though this is an abnormal report, it does not mean he's sterile.
So what are normal for like the motility?
Oh, the motility, again, I may have to just pause, but normal morphology, which is the way they look, should be more than about 30%. Well, this gentleman had 82% normals. And then motility, more than 30 to 40% of them should be swimming, should be motile, not 100%. Virtually every egg that a woman makes is perfect. Virtually every sperm that a man makes is defected. I don't know, go figure. We're genetically inferior, yes. LUF, what's the treatment for the large luteinized unruptured follicle? Short answer is a shot of progesterone. I'll show you a picture. So I'm going to leave male factor. I wish I didn't have to. This is the short luteal phase. Remember her? She only had a 5-day luteal phase. This is where we check her progesterone. Look, it should be up here by 20. And look at it. It's inadequate. All she needs is post-peak bioidentical progesterone. That's going to fix her luteal phase defect. This is a limited mucus cycle that I showed you. Her estrogen is pathetic. She just needs estrogen in the pre-part of the cycle. She's going to have normal mucus production and conceive. This is a LUF. Now, the important thing about a LUF is what happens to a 21-year-old girl in virtually every emergency room in America. So she has 5 days of severe left lower quadrant pain, hopefully not right, because they're going to think it's your appendix. Left lower quadrant pain. She goes to the ER, middle of the night. It's always the middle of the night. They do an ultrasound and they say, you've got a large, complex ovarian cyst on the left side. Really good probability she's going to get operated on, if not that night, within the next week. Even better probability she's going to lose her ovary. Somebody's going to go in and take that ovary out for something that is very common and very easy to treat. The way that we treat this, these are estrogen-dominated cysts, and this debris that you see inside is probably blood, so they bleed into themselves. That's why they hurt. They're estrogen-dominated. We can give a woman a large dose of an intramuscular injection of progesterone, scan about a week and a half later, and virtually always these are gone and her pain resolves in 3 to 5 days. So the best advice you could give a young woman if she has pain, don't go to the ER in the middle of the night if you can help it, and don't let a gynecologist take your ovary out. These don't need to come out. Now, here's some interesting data. This just doesn't project, but this is from Dr. Hilgers at Creighton. 45 women with big cysts, right? We treat them with intramuscular progesterone. 38 of them disappeared. Of the 7 that didn't disappear, they were all important things. 3 of them were serous cystadenomas. That's a tumor that needs to be operated on, right? 2 of them were peritubal cysts, cyst on the tube, not even on the ovary. She would have been operated on for an ovarian cyst that wasn't an ovarian cyst, right? One of them was a mucinous cystadenoma, which is another tumor, and the other one's a mucinous tumor of low malignant potential, a precancer. So not only is giving them a shot of progesterone helpful and it relieves their symptoms and it goes away, it's also diagnostic. If it doesn't go away, they need to be operated on. So we do this very commonly in our office. That saves a lot of unnecessary surgeries. Quickly, stress messes you up. Any questions? Yes.
You were going to share your journey from
I know.
non-conception to Creighton.
You want me to shut up and tell that part of the story, don't you? Okay. I will. You may not get to eat lunch, but I will. Stress messes things up. Quickly in pregnancy, because this is important. There's hardly something more pro-life than this. So this comes from Creighton University. It's the normal progesterone curve every 2 weeks in a pregnancy, right? So they've got 3 decades of data in a database. They say, show us every woman that had a stone cold normal pregnancy. No preterm labor, no premature rupture of membranes, no bleeding, no growth restriction, no nothing. Show us what her progesterone was. And that's where we get this line. 1 standard deviation above, 1 standard deviation below. So when we see someone that's at risk in pregnancy for miscarriage, for recurrent loss, anything at all, if she just looks funny to us, we check her progesterone level. And when it comes back, if it's down here, we replace it using the Creighton protocol. This works. Recurrent miscarriage, preterm labor. This is a true story. Someone from my office here can confirm it. I used to do all my surgery at one hospital because I was employed there. So I deliver about 30 babies a month on average. I learned in school that 1 in 10 pregnancies will miscarry, right? So most miscarriages, a lot of them, result in a DNC. That's a surgical procedure in the operating room. After I converted to Creighton, not too long, maybe 6-8 months, I get a call from the manager of the operating room who wants to know what they did to offend me because I must be doing all my DNCs somewhere else. I'm not doing any DNCs because we're not having losses. Now, that's not 100%. There are still some losses. There are other causes of losses besides low progesterone. But if you believe life starts at the moment sperm and egg meet, and then you learn that there's something you can do to maybe prevent a loss, then you want to go all out and find their progesterone problems and fix them. And we do, and it works. Yes.
Start making progesterone. But I'm currently pregnant, and I've been told that Creighton and Navro don't necessarily agree. Can you speak to that?
Yeah, good question. A lot of gynecologists support progesterone in the first trimester, especially infertility physicians, and then they say by then, at 13, 14 weeks, it kicks in and it's normal. You could say to that, a bit cynically, prove it. Check my progesterone and plot it on the Creighton graph. Now, you can only get this graph from Creighton. I mean, it's online, it's free, but this data only exists in Omaha because hospital labs give you normal progesterone by trimester. Well, I don't want to know the whole 3rd trimester what it should be. I want to know what it should be at 26 weeks specifically, right? So I would argue if you have progesterone problems in the 1st trimester, there's a darn good chance you have them in the 2nd and 3rd. I'm going to get to my journey. This is a graph. Yellow means low. This is progesterone levels in women that had abnormal placentas. Look at that. Their progesterone is low in every case. This is women that had threatened premature birth. Their progesterone was low in every case. This is women that had fetal distress in labor, and you look back, their progesterone was low at every point along the pregnancy. So, by extension, if we replace their progesterone and make it normal, maybe we can avoid all of these complications. It sure seems like we do. I still have patients who have preterm birth. I still have patients who have complications, but nothing like I had for the decades that I practiced as a regular OBGYN. I'll skip those. I want to tell you my journey, but I want to give you an important pro-life anecdote. So 2.5 years ago, roughly, I get a call from a woman who, she's in the Kosciuszko emergency room with 17 weeks. The emergency physician told her that her membranes were ruptured. So they called in her OBGYN, and he said, well, we've really got 2 choices. We can do the DNC now on your live baby, that is, an abortion, or you can go home until the baby dies and then come in. Well, for whatever reason, she thought those 2 options weren't optimal. So in the ER at Kosciuszko, she Googles stuff, and somehow she finds me, and somehow she checks herself out of that ER, drives about an hour and a half to Fort Wayne, shows up in our ER. To this day, the nurses and I can't remember how she got to me. I wasn't on call. The nurse who brought her from the ER doesn't remember why she brought her and how we met. I think we know, but nobody can explain how we met. So I started her on the Creighton salvage protocol, it's called, for extreme premature rupture of membranes. It's high-dose antibiotics and a permanent IV line that goes in called a PICC line, and it's high-dose progesterone, right? I warned her, I said, I haven't done this, but I learned at Creighton that everybody's going to think this is dumb, and any other physicians that come in are going to tell you it's a waste. She wasn't interested in that. We started the protocol. She's in the hospital. I'm gone one day, a maternal fetal medicine expert comes in and tells her, you're wasting progesterone, the antibiotics aren't going to do anything, it's only a matter of time until you lose your baby. She had the wherewithal to say, get out of my room and don't come back. We sent her home because we were afraid of what would happen to her in the hospital. So she went home at 18 weeks with ruptured membranes. You know what happened after that? Nothing. 18 weeks, 19 weeks, 20 weeks, 21 weeks, 22 weeks, 23 weeks, the baby's viable. So we bring her back into the hospital in case she goes into labor. 23 weeks, 24, 25, nothing's happening. The nurses are electrified. She has this cult-like following in the unit because now she's been in the hospital forever. She's got posters in her room. The nurses all know her by name. She's got flowers. 28 weeks, she went into labor. She delivered this baby named Willow. So I like to say Willow is the baby that most of my colleagues wanted to abort. She spent about 6 months in the NICU. She's got problems. She has respiratory issues, but she's alive and well because of the Creighton model fertility approach to preterm ruptured membranes. I think that's a powerful, powerful story. More powerful than my journey, but I'll give you the 2-second version of that. Point one, I married well. That helps. So I'm new to the faith. My father-in-law, who's a cradle Catholic, likes to say, God save us from converts, right? But I'm new to the faith, came into the church 2007. At the time I wasn't practicing, I was an administrator. So I learned all the stuff, contraception, sterilization, blah, blah, blah. It didn't matter to me because it didn't matter. It didn't apply to me. I wasn't seeing patients. A couple of years go by, I get back into practice. Whoosh, right in my face. I thought, well, that's a problem. The church says I'm not supposed to do all this stuff, but I'm an OBGYN. You know, you can't be an OBGYN and not do contraception and sterilization. You can't be a police officer and not carry a gun. I am what I am. So, like most physicians, I thought I had an exemption. Right? I thought, you know, physicians, we don't think the rules apply to us. So I kept doing what I was doing, but it was bothering me. I don't have time to tell you the whole story. I was doing some mission trips, which were really centered on sterilization of young women. That bothered me, so I quit going on those. But I was still prescribing. I was still doing all the stuff. Well, where most great things happen in the confessional, I said in passing to the priest, I said, yeah, you know, I'm prescribing contraception and I'm tying tubes and I'm putting in IUDs and, you know, it bothers me. But anyway, as I was saying, he puts his hand on my leg. I thought, now I'm new, but I don't think they usually touch you in confession. He puts his hand on my leg and he said, with saucer eyes, you know, he says, you think this is a problem? He says, have you thought about burning in hell? And I said, well, not really, no. So he says, you got to make a change. You got to make a change right now. So I thought, well, this, you know, okay. I mean, I don't know what I'm going to do. You don't understand. I'm an OBGYN. This is what we do. He introduces me to Patrick Holly, who's a family physician, who's an early Creighton provider about 8 years ago in our market. He says, you got to go see him. I go see Patrick. We meet to have a beer. We sit down. We have our beer. We're being very manly. He says, well, I'll tell you all about the Creighton Method, but you got to read this. He hands me a large print version of Humana Vitae. And I said, oh, okay, I'll read it. He says, we're going to read it now. Okay, we go through Humana Vitae. It takes all of 30 minutes to read Humana Vitae. I read it and I was convicted, right? You can't read Humana Vitae and not be convicted. It's impossible. So I read that. So he tells me about this Creighton Method. I thought, oh, that's perfect. You get a credential. Physicians, we love credentials, right? We like letters behind our name. We like titles. I can do this. I'll go to a course and I'll get a credential and I'll be good. That'll be perfect. Because I thought I can't tell women I don't prescribe birth control, go away. I need to say I don't prescribe birth control, but I do this. So he provided me the this. So that's great. I call Omaha. I get registered for a class. It's about a 1.5 year commitment. I'm all signed up. It's great. I get a call from the lady at Omaha to be a medical consultant. She says, we just have a problem with your application. And I thought, oh, I know. I use blue ink. You're supposed to use black. You know, what did I leave off? I'm not good at doing applications. Physicians were not. She says, I'm reading here, and it says you've had a vasectomy. And I said, oh, yeah, I did. That's when I was a Protestant. I was stupid. I didn't know any better. But, you know, the church says I don't have to change that now. She says, that doesn't work for us. I said, what do you mean it doesn't work for you? Why do you care what kind of surgeries I've had? She said, you can't be a medical consultant if you're not using the method. And I was standing in a conference room and I remember thinking, oh my God, this is not good. I had it all worked out. And so I said, well, I can't do it. I'll send my money back, I can't do it. So this young woman, I've actually forgotten her name, she says, well, before you give up, could I just tell you kind of a wacky story? And then you do whatever you want to do. Now maybe you guys know this story, but I'll tell it anyway. It's not that long. It's about the wedding invitations, right? Nod your head if you know this story. I don't see any nods. You know this story. So she tells me the story. She says, when you're planning your wedding, there are those people that you send an invitation to that, you know they're not coming. You're in Indiana, they're in California, they're not coming, you know they're not coming, they know you know they're not coming, maybe they're friends of your parents, but you send them an invitation anyway. Then there are the people that you send an invitation, you don't think they can come, but you really hope they can come. And it'd be great if they do, but you'd understand if they don't. Then there's the group of people that you know are coming. You don't even have to send them an invitation. They've already decided they're coming. They'd come if you didn't invite them. So you send those invites. She said, when a couple engages in the marital embrace and they're contracepting, they're saying to God, you're in that first group. You're not invited. Don't show up. There's no room for you. Don't even come. We're not sending you an invitation. She said, when you don't contracept, if you're engaging in the marital embrace outside of the fertile window, you're saying, you're invited. I don't think you're coming, but you're always welcome to show up. So she tells me that story, and I'm standing there thinking, this is really weird. This woman I've never met has just convinced me I've got to have surgery to get a credential. So I meet my wife. She'd been on a retreat the weekend, and the closing session of the retreat, she's there, lots of people around and cheering and laughing, and I hug her and I say, I met this woman on the phone, and I want to get my vasectomy reversed. And as I said, I married well. And she said, great, we're going to have babies. I said, well, that wasn't exactly what I meant by that. You can use this method to avoid. That would be fine too. One thing led to another. I had the vasectomy reversed. I didn't find out if it worked. I still don't know. We haven't been pregnant again. But if we are, that'd be great. He's invited. I hope he comes. So I heard that story and I converted. Well, then we saved up for our mortgage because an OBGYN that doesn't prescribe oral contraceptives, that does this weird method nobody's heard of, is destined to be broke, right? So we're worried about mortgage payments. I'm new back into practice. We think, this is going to be ugly. This is really going to be ugly. But I did it anyway. You're supposed to step out in faith. See what happens. We're stepping. I write the letter to my patients. I'm not prescribing. I'm not sterilizing. I'm not putting IUDs in. But I hope you'll still come. Nobody's going to come. And guess what happened to my practice? It grew. And it didn't just grow a little. It exploded. It grew the first week. It grew the first month. It grew the second month. It grew so much I couldn't control it. It grew so much. Now it changed. I don't see 22-year-old women looking for the pill. I don't want to see them. They don't need to see me. And I don't see a lot of the routine things that OBGYNs might see. But I see a huge number of people that are having fertility problems that are not going to abandon their faith for their fertility. And it's an absolute miraculous transformation of a practice. So I see part of my role is convincing you to convince your physicians that they don't have to choose between their profession and their faith. I didn't, and the success has been unbelievable. In September, we opened our own practice. We left the mainstream group I was in. We opened our own practice. By all indications, it's been hugely successful. It turns out God likes it when you step out in faith. So I've destroyed your schedule knowingly and apologetically. I'll stay as long as you want me to stay. I'll just stand up here, get food, come ask me questions. I've got to leave in a little while. I can't stay the whole day. I wish I could. But I'll stay up here and answer and talk to you as long as you want to talk. We have some materials from our practice if you're interested. If you know someone that would like to talk to me by phone, I do phone interviews with patients, huge distances all the time. I'm happy to do that. But thank you. Thank you for your interest. Thank you for your dedication. God bless you. Thank you.